good segue after the previous two speakers. These are my disclosures. So varithena, basically, you all know, is an FDA-approved foam within the United States, not available elsewhere. It's a 1% polydocanol injectable foam straight out of the canister with very low nitrogen, which is purported to be the cause for the neurologic issues that are seen in physician-compounded foam treatment. So my assignment is to talk about the VIEW-VLU observational study, which was initially OHVLU, which is Ohio Health Venous Leg Ulcer Study, which I headed, and then it was converted into a multi-site registry within the United States and within Canada. As you can see, the authors, the study was published in July 2023. The goal was about 100 patients, but it was terminated early by the sponsor because of COVID, and 80 patients were enrolled. The primary objective and endpoints of the registry were rate of epithelial migration, ulcer healing at 12 weeks, and time to heal in these patients with C6 disease. The way the wounds were measured were patients were given these Android devices with tissue analytics software that was installed on it, and the patients took their own pictures. And the parameter was assessed by an independent physician, and not necessarily a core lab, but it was done independently for sure. So the important things are the inclusion-exclusion criteria. Basically, all we needed was the reflux of greater than 500 milliseconds had to have a venous ulceration, not some other ulcers, and that the ulcer be visualized in one plane by the iPhone or by the Android device. Some exclusion criteria are listed there, usual stuff like arterial disease with less than ABI or less than 0.8, and some investigator-related things when they felt that it was not a good patient to be enrolled. So these are the demographics here. I wanted to point out to certain demographics that are pointed out here for your convenience. As you can see, the average BMI was 36.3. More than 30 BMI was seen in half or more of the patients. Circumferential wounds accounted to 26%, and the age of these ulcers, which there was no exclusion criteria, was 24. And multiple other modalities were also done on these patients. So these were difficult ulcers. And when compared to the EVRA group, the BMI was high, the ulcer was high, the ulcer age was also older, and the VCSS score was slightly elevated, as you can see. In terms of the procedure itself, 68% received only one session, remainder had two, and you can see the volume of the varithena injected above and below, and this is more than the physician-compounded foam, which usually we restrict to 10 cc's. So the median time to close for these ulcers were 73 days, as you can see, and the wounds remaining closed at 3 months were 87%. So not a bad thing. The pain and discomfort score also improved, as you can see. Only two adverse events reported. One is asthenia and the other one is pain. Nothing else was identified. Since then, I wanted to see any other ulcers and varithena papers. There was this one single-center retrospective study reported. As you can see, 1 month wound healing in C6 patients was reported at 69% compared to laser, which was 5%. Nothing else I could see, and other speakers have mentioned there's no head-to-head RCT kind of thing. So the new guidelines recommend the non-thermal techniques, which included varithena, the PEM, alongside with thermal ablations, as you can see, for patients with axial reflux. The VLU guidelines revision has just started, so hopefully by next year we'll have some data on that. And in terms of the tributary treatments, also, as you can see, I highlighted at 7.2.1 there, strong evidence that it is on par with mini phlebectomy based on the evidence available. I think I'll stop there. Thank you.